Good evening. IMA Chennai Kauvery Alwarpet branch proudly presents this webinar, which is first of its kind for us, but it's going to open the door for many such meetings in the future. I'm Dr. Bhuvaneshwari, neurologist and secretary of this branch. I also extend a warm welcome to all on behalf of our president, Dr. Sivaramakannan. Today we'll be focusing on emergency and critical care management during pandemic. We have two speakers. First speaker is Dr. Sridhar, our chief intensivist, who will be speaking about the management of patients who have severe COVID infection. Our second speaker is Dr. VijayaLakshmi. She's our infection disease specialist. She will be talking about evaluation of patients with fever. I hope you will have a very enlightening session listening to both our expert COVID warriors. And please pose your questions at the end of the session to our experts. They will answer your questions. Thank you. Enjoy this session.
Good evening, one and all. Thank you, Dr. Bhuvana, for the kind introduction. So today is actually my day off. I'm here in Chennai and working in one of the busiest ICUs in Chennai. So I asked my management, can I have one day where I don't see anybody with COVID, where I don't think about COVID? So management, with their twisted sense of humor, said, right, here is a day off. You will not see anybody COVID. You will not think about COVID, but you will end up talking about COVID. So here I am in front of all of you. I'm going to talk about my experience with COVID over the last few months. So my topic is management of severe COVID. And I thought I'll break it down into what I'm going to cover. I think COVID is a illness which has got a wide spectrum. You can have somebody who's completely asymptomatic. At the other end, you can have somebody who's got severe organ failure, needing life support in ICU. So I think what becomes important for all of us as practicing physicians is to be able to recognize the sickest one of them, the ones that are classified as severe COVID. And then what tests we do to help us in further management and what therapeutic options we have for them. So by and large, my philosophy in managing any patient is less is more. Use the minimum number of medications, the minimum number of interventions, only those that have been proven by evidence to work to manage these patients. Because as you know, most medications interventions have either side effects or complications, which we are keen to avoid. I strongly believe in the less is more philosophy. To summarize, COVID is essentially an immunothrombotic illness. You have a viremic phase, and then you have an immune response, and we know there's a lot of thrombosis that is happening. And the main target organ, although it can affect any part of the body, appears to be the lungs, and the most severe patients end up having acute lung injury or ARDS. In common parlance, it is nothing but wet lungs. The lungs are extremely wet, and this is what causes most of the problems. So how do we know those patients, of all the patients with COVID, who are those that are severely affected? It's quite straightforward really. The asymptomatic ones are quite obvious. They have it, they carry it, but they don't have any symptoms. The mild ones have symptoms. The symptoms we all know about: fever, cough, loss of sense of taste, loss of sense of smell, extreme weakness, sometimes diarrhea. The patients who fall into the moderate category have these symptoms and may additionally have clinical or radiological features of pneumonia. So how do we identify those who fall into the severe category and those who we need to worry about, and those will almost certainly need us to admit them in hospital and keep a close eye on? One, they usually present with sensation of dyspnea. They say as they do their normal activities, they're getting more and more tired or more breathless, although some of them may not have the symptoms. I look for three things in this patient. The first time is I look at the patient and see if there are any signs of respiratory distress or any signs of tachypnea. So for want of a number to help us diagnose, anybody with a respirate more than 30 I would worry about. And the signs of tachypnea are people who are working really hard to breathe while they're talking to me, who are using their accessory muscles of respiration, or those who are unable to talk in full sentences. The other test we use is a pulse oximeter. It's quite widely available, and you just put a probe on and the saturation is less than 93, then once again that's a worrying sign. We can do RT-PCRs, but they take time to come back. So the next best alternative is to get a CT or a chest X-ray. Personally, I would prefer a CT if that's available for you. And when the CT reports come back in our hospital, one, they tell us about how likely it is going to be COVID, how certain they are, and also how severe the COVID is. So we use a scoring system which scores the severity of lung injury out of 25. So anything more than 50% lung involvement is bad, which equates to a CT score of about 13 or 14. So anybody with a score of more than 13 or 14 or 25, which equates to a lung involvement of 50%, says this person has got severe COVID. And then the next stage is the one who are critical and they have organ failure, severe ARDS needing ventilation or shock. So how does the illness proceed? From the day of onset of symptoms, usually patients have symptoms for the first week. They don't usually tend to present severely ill in the very first week of symptoms. The first week is usually the viremic phase where the virus is replicating. It is usually when they go into the day 6, day 7 after illness, when the immune response to the virus kicks in, that we start seeing them getting more and more dyspneic and they start becoming sick and they might need to come to the ICU for this. So this is an illness that is worst in the second week. What tests we do? It's quite standard really. Complete blood count, renal function tests. We do a CRP as an assessment of how much inflammation is going on. We do D-dimer because we know that this is an immunothrombotic illness, so we need to be wary of those people whose D-dimers are high or showing a rising trend. We need imaging to quantify the extent of illness, and if you're worried about there being a bacterial superinfection, then we need to do procalcitonin and blood cultures. Generally, the white cell count in pure virus illnesses is normal. That's what we find. So quickly moving on to the treatment options. I use the 4 Ds. These 4 Ds are standard for anybody with severe COVID. The 4 Ds being diuretics, dalteparin, dexamethasone, and down facing, in other words, lying prone. So let me just go over this gradually over the rest of the talk, and then I'm sure you're all eager to ask us in the question and answer session about the various new medicines, tocilizumab, remdesivir, colchicine, favipiravir. These are not our standard management. So as I said, in the investigations itself, we do not do interleukin 6 levels or ferritin levels routinely. They are inflammatory markers. We expect them to be high, and I do not think there's any added value by doing these tests on patients who are coming in. Likewise, these other medicines like tocilizumab and remdesivir, we do not use routinely. We use it only if the family insists that we use something or the patient is becoming more and more severely ill and we have no other options. Then on compassionate grounds, we can use tocilizumab or remdesivir, but they are not our standard of care. We do not use them in routine practice. So you might ask me, if you don't use these drugs, what do you do in a routine practice? Okay, so one of the things that we know is that this is a viral ARDS, and 2 proven therapies in viral ARDS who are not on intubation, who are not ventilated, is one, negative fluid balance or conservative fluid balance. So what this means is we must definitely not get these patients into a fluid overloaded state. So sometimes I have patients who are coming from other hospitals who have got severe COVID and they have been routinely started on fluids at about 100 ml per hour. And 100 ml per hour is almost 2.5 liters a day. And we have good studies in other patients with viral ARDS. In those people who have conservative fluid balance or neutral fluid balance or negative fluid balance, their length of stay in ICU is less, their duration of being on the ventilator is less, and there is also a trend towards decreased mortality in people who have been managed conservatively with fluids. In other words, try and keep these people either neutral balance or even negative fluid balance. If they are not very ill, I tend to give them furosemide 40 milligram twice a day to try and ensure that their lungs don't get wet, because the ultimate pathology in these people is ARDS or wet lungs. So I would like to run my patients dry. If you do not want to do that, please ensure that your patients are not getting overloaded. Ideally, dry. I'm very happy if they say Today, the patient is negative fluid balance of 500 mLs. And this is my experience. So this is a patient who was transferred to us from a different hospital on 100% oxygen, saturating about 90, almost certainly going to be intubated. We started aggressive dialysis. So I said, I gave furosemide 40 milligram IV BD, but this patient was quite sick that we started this patient on a furosemide infusion of 10 milligram per hour IV, and this is his X-ray 48 hours later. And I'm pleased to say that this patient we managed with high flow nasal oxygen and non-invasive ventilation without needing intubated ventilation. So diuretics is my first D, or if you're not yet convinced, at least conservative fluid balance without trying to get them too positive. My second D is dalteparin. Once again, this is just a way of making it simplified for me to remember. By dalteparin, I mean low molecular weight heparin. We know that this is a thrombotic illness. We are seeing an increase in number of young people who are presenting with large strokes due to big clots in major vessels. We are seeing an increase in the incidence of pulmonary embolism. We are seeing an increase in the incidence of DVT in patients who have suffered from COVID. So what do we do with these patients? How do we prevent these complications from happening in these patients? We all know what the prophylactic dose of dalteparin is. It's about 5,000 units subcutaneous once daily. We also know what is the treatment dose of dalteparin. It's about 7,500 units twice a day. And this is used in people with DVT, with proven pulmonary embolism, to actually treat these people. So what I do is a half measure. So the patient has got moderate illness and is admitted to hospital and is walking about doing their normal activities, then I give them only prophylactic dalteparin. But if the patient is needing oxygen, by definition they become critical, and it means because they are on oxygen, their mobility will be restricted because they might be able to take the nasal prongs off for a short while, but when they come back, their mobility is restricted. So rather than go in for treatment dose dalteparin, which has got other side effects, remember, so I would use a halfway house in between. I tend to use intermediate dose dalteparin, which is dalteparin 5000 BD, in people who are hypoxic and admitted to the hospital. So by this, I'm hoping to reduce the incidence of thrombosis without exposing them to risks of full dose anticoagulation. When would I use full dose anticoagulation? In those who have confirmed that there is a clot in the legs by using a venous Doppler, a popliteal vein thrombus, or in whom I've done a CTP and found a PE, or in somebody, if you ask me an arbitrary value, then somebody with a D-dimer value of greater than 3000, normally it's less than 500, I would probably go for treatment dose dalteparin in this group of patients. What are the other options we have? Dexamethasone. This is the only drug proven to save lives in people. So you all must have come across this recovery trial that was done in Oxford. So a simple drug, a cost-effective drug that is proven to save lives. But I think we must be careful in which group of patients we use to. If you remember my initial slides, I said that the initial phase is one of viral replication phase. It's only after the first week that it is the immune response phase, and this is when patients go into hypoxemia and lung injury. So dexamethasone must not be used early on in the illness. It must not be used in hypoxic patients where it can actually cause harm. But definitely it has to be used in those people who are hypoxic needing oxygen or those on the ventilator. And we all know what a wonderful drug dexamethasone is, but I want to draw your attention and give you a different perspective. Rather than saying dexamethasone saves lives, we can look at this concept of number needed to treat. How many people needed to be treated with dexamethasone for one additional life to be saved? So this is what this is about. So for patients on ventilator, if we use this wonderful life-saving drug, for every 8 patients who are treated, only one of them, one additional life will be saved. Okay. Whereas if you treat people with hypoxemia, we need to treat 25 people with hypoxemia for one additional life to be saved. And now you understand that 24 people may not benefit. And if you use it in non-hypoxic people, not only do you not give this drug to people who do not benefit, you can actually cause harm. And remember, we're using drugs like dalteparin in these people, we're using drugs like dexamethasone, all of which will increase the risk of GI bleed. So you must be very careful and use these drugs only in appropriately chosen patients. In other words, those who are hypoxic or on the ventilator. The one thing that is very dramatic, and you can watch the patient's oxygen levels improve in front of your eyes, is awake proning. I'm sure you all come across these words wherein the patient is on oxygen to whatever source you're willing to give, whatever system you're willing to administer it through, and then their saturation is about 85, and then you turn the patient and make them lie prone, awake. In a matter of 10 to 15 minutes, you can see their oxygen levels go up, and it's quite impressive, particularly in some people where the oxygen levels can go up from 85 to almost 95, 96, and some people even 99%. We know prone ventilation works in viral ARDS. There are a lot of studies that have shown that it works. In these people who are intubated and ventilated, there is no doubt that prone ventilation is good for them, and it's a standard of care in ICUs all over the world. And when we prone them, we try and keep them prone for 18 hours. It may not be possible to achieve such lengths in these people because they are awake. If they are able to keep themselves prone for as long as possible, I would be happy with that. I would try to push for at least 2 to 4 hours for maximum benefit, but I have seen quite a few patients who are determined and lie much longer than that. So how does proning help? It's a very simple measure. How can something as simple as proning helps? I mean, we all know what ARDS is all about. ARDS is wet lungs. So we have alveolus, we have capillary. So you have the ventilated alveolus that's full of oxygen. So the blue blood going in the capillary to that becomes oxygenated, comes out as red blood. On the other alveolus, on the other hand, is wet. It's full of fluid because of ARDS, or the alveolus is collapsed. So the blood flow to this alveolus, which is not taking part in gas exchange, is going to carry out deoxygenated blood. So there is a ventilation perfusion mismatch, and this is why there is hypoxemia in these patients. So how will proning help? The alveoli are full of fluid. How does making them lie prone suddenly improve oxygenation? I think the analogy that best enables us to understand this is, in case of ARDS, the lungs are wet. They are like a sponge that is wet. So if we dip a sponge in water and we take it out, after all the water leaks out and we put a sponge on the table, you know that the bottom half of the sponge contains more wetness. It is more wet than the top half of the sponge. Just by gravity alone, we understand that this will happen. If you'd say the lung is a sponge, then in somebody who's lying down, whichever position, the dependent alveoli are much more likely to be wet. So if you look at it, if you see the lung as a sponge, and you see the top picture where you can see two round sponges as an analogy for lung, in the dependent portion, below the halfway mark, you find that the alveoli are wet, just like the wet sponge, whereas the alveoli in the top half of the sponge are round and full of air, and they can take part in gas exchange. And now this becomes even more interesting. So what happens if you prone them? Okay, the lungs that were initially in the front are now going to become wet, and the lungs that were in the back are now going to become free of lung. So 50% of lung, irrespective of which position the patient lies in, is going to be wet. So how does really turning patient from supine to prone really improve things? Irrespective of the position, half your lungs are going to be gone. This is where a little bit more insight into how it works makes it a lot more interesting. So if you look at the shape of the lungs, they are not rectangular like your average sponge, they are not oval or round. If you look at a CT scan, the top CT scan, the closest geometrical figure that comes to mind is the lungs are triangular. They have an apex at the top and a wide base. Both the left lung and the right lung, they have an apex at the top, and they're actually triangular in shape. And now when we understand this and we go back, and now if you see, when the patient is lying supine, most of the lungs are at the back. So almost 75% of the lung, if you look at the bottom picture, below the halfway line, 75% of the lung is atelectatic or collapsed and not able to take part in gas exchange, and only 25% of the lungs are open and able to take part in gas exchange. And now if you prone them, we see that the part of the lung that is collapsed is only 25%, and now 75% of the lung, which originally formed the basis when patient was lying supine, are now open and able to take part in gas exchange. So it's not 50-50 like in the usual figure, it is more like 25-75. And this is called shape matching. For those of you interested, you can go and look up shape matching in ARDS and you can read up a lot more. The other thing we need to remember is, in the supine position, the heart is an anterior structure, like in the top picture here. It's going to press backwards on the lung, and already this lung is atelectatic, wet and collapsed, and the weight of the heart squeezing the lungs makes it even more harder for these alveoli to take part in gas exchange. But the moment you prone them, the heart, which is an anterior structure, is going to come forward and lie on the sternum and the rib cage, it is no longer compressing the alveoli, and you see a lot more alveoli are able to take part in gas exchange. So this is the physiology behind how making somebody prone actually helps improve oxygenation. And this is a critical part of the way in which we manage our patients. Anybody who's hypoxic, after we ensure that they've got conservative fluid balance, we see how we can prone them and how long they can lie prone to improve their oxygenation. Once we have done all this, we choose a variety of oxygen systems. Not all of us may have all of this available. So nasal cannula anywhere between 2 to 6 liters to try and improve oxygenation. If that doesn't work, we can use Venturi mask, which can go up to 60% FiO2. And then my next favorite device is the high flow nasal cannula at the bottom. This is able to give 60 liters per minute of oxygen, and it can give FiO2s up to 80-90%. But what would you do if you have a setting wherein you do not have a high flow nasal oxygen system? Then we must use the poor man's high flow nasal oxygen system, because remember, as we move to a more and more higher, more expensive system, what we are able to do is able to give a high flow of oxygen, able to meet the peak inspiratory flow needs of this patient who is hypoxic. So in nasal cannula and Venturi mask, maximum can give 4 liters, 10 liters, something like that. But if you're really struggling and you have a sick patient, you do not have access to high flow nasal oxygen or NIV, then a trick that you can do is you need 2 oxygen sources for this, either the 2 wall mounted oxygen, or you have 1 wall mounted oxygen, 1 wall mounted oxygen, and an oxygen cylinder. So you connect the nasal cannula to the oxygen cylinder, put it onto the patient, and give 6 liters, 8 liters through it. On top of this, you can put an oxygen mask onto the patient, preferably one with a reservoir bag, and then you connect it to a wall mounted oxygen source and give 15 liters per minute. So in this way, we are trying to give more and more peak flow of oxygen. Be very careful if you're working in a setting wherein your oxygen flows are limited, because you will be using a lot of oxygen in these systems. And another trick is, often you say 15 liters per minute is what your oxygen flow meter is, but turn it anti-clockwise more and more. You can give quite a bit more than the 15 liters per minute that it says on the flow meter. If you have access, then there's nothing like a high flow nasal oxygen system, because not only does it give high flow, it also humidifies it and possibly blows out a little bit of carbon dioxide because of the high flow going through the dead space, and possibly also generates a little bit of PEEP, especially the patients keep the mouth open, which can recruit collapsed alveoli. When all this don't work, or the patient has got background problem like obesity, hyperventilation syndrome, or obstructive airway disease, then we might have to use the NIV. The NIV is a way in which we can give either CPAP, which recruits collapsed alveoli, or we can even give a bit of support to eliminate carbon dioxide by giving 2 levels of PEEP, the IPAP and the EPAP. We normally start at 5 and 15 FiO2 of whatever is required to keep the saturation above 90. And if all these fail, then we'll have to end up intubating the patient. I'll not go into how we end up intubating the patient, into what precautions to take while intubating the patient. These are all widely available on the net. How do we decide that patient needs intubation? So respiratory failure, 2 types, type 1, type 2. So severe hypoxemia, despite maximal oxygen you're giving, the patient saturation remains low. I personally am comfortable when the patient saturation is about 90%, but if despite your maximal oxygen therapy, patient saturation is low and patient's oxygen levels are deteriorating, or your carbon dioxide levels are rising, so dropping SATs, dropping PO2, rising carbon dioxide, or the patient is becoming more and more encephalopathic and less able to cooperate. So some patients are there sitting on a lot of oxygen, but they're fully cooperating with you. You can have a decent conversation with them. They try and help themselves as much as you can, and quite a few patients fall into this group. Then we can persevere a little bit longer without intubating them. But once they start getting encephalopathic, once they start getting tired, once they start becoming unable to cooperate, unable to lie prone, then you're heading towards intubation. The other sign is clearly they're starting to fatigue, and even talking to you exhausts them. Okay. So once you go on the ventilator, what do we do? Once again, we know from our previous experience in dealing with ARDS that tidal volume is very important. 6 mLs per tidal, 6 mLs per kilogram. In other words, no patient with ARDS should have a tidal volume more than 450 ml. Nobody should get more than 500 ml. Ideally, 400 to 450 should cover most people with ARDS. Anybody getting more than 500 ml, your ventilation is doing more harm than good. And then we can do an inspiratory pause on your ventilator. measure the plateau pressures and try and keep the plateau pressures less than 30 centimeters. One thing we are finding in people who are ventilated with ARDS is the amount of PEEP that they need is less. We are finding that as we titrate the PEEP up and down, they're having maximal tidal volume, maximal compliance on the pressure control mode at a lower PEEP. So I'm finding most of the people who are ending up on the ventilator are comfortable using lower PEEPs. This is something to watch out for. This is a patient who has had ARDS for quite some time. You can see some fiber optic changes, but you can also see cystic changes. So these patients, if you use very high airway pressures or very high PEEPs, must always be aware that ventilation can cause pneumothorax in these patients, something to watch out for. So to summarize, it is important to recognize patients who are sick. So these are patients who are either complaining of breathlessness or have saturation less than 93 or whose respiratory rate is more than 30 or who have got extensive lung involvement on CT. For these patients, it's important to maintain conservative fluid strategy. Definitely do not get them fluid overloaded. If you believe what I say and you believe negative fluid balance is good for them, please use diuretics. In patients who are stable, we use 40 milligram IVBD. In patients who are sick, we use 5 to 10 milligram per hour. And when you use it, I see my patient's urea rise. So our normal urea range is about 15 to 45. I would accept the urea going up to even 90 or even 100 as a sign that we are running them dry. The second thing that we do is we put them on intermediate dose dalteparin, especially if they've got severe COVID, which is dalteparin 5000 units BD. Clearly, they're going to renal failure. You need to modify the dose adjustments. We put all our hypoxic patients on dexamethasone, 6 milligram once a day for 10 days. And we encourage our patients to do proning. We do not routinely measure interleukin levels or use tocilizumab or remdesivir. But in patients who are deteriorating despite maximum treatment, we would consider either of these two options and use them if they are available, although it is not our routine standard of care. Thank you, and I look forward to your interacting with you on the question session.
Vanakkam. Thanks for the kind words, Bhuwana. So after this exhaustive session with Dr. Sridhar, we are going to have a simple session. We're going to discuss about how to handle a patient presenting with fever during this pandemic. So starting off, I'm talking only about acute fevers now. I'm not talking about prolonged fevers. So COVID doesn't really present with prolonged fevers. Management of prolonged fevers is not going to change much. So somebody comes with acute fever, 2 weeks. We are worried it could be COVID, it could be non-COVID. How do we assess them? How do we go about? How do we protect ourselves? That's what we're going to discuss in the next half an hour or so. So when somebody comes in the usual variation, the age, sex variation, like female have certain predisposition, male children have some predisposition, immune differences like diabetes, patients with CKD, they have different kind of infections, exposure to another patient, all those things we take into consideration. And also when they come present to OPD, either to fever clinic, ER, inpatients, the differences come there too. So we'll start off with the presentations in COVID. The common presentations COVID is usually a flu-like syndrome, fever, cough, cold. This can happen in a flu also, your usual influenza. They can present like an atypical infection, atypical pneumonia with respiratory failure. Again, it can come with any kind of respiratory infection. They can present as an MI, acute heart attacks. They can present with diarrheas. In children, they can present as an acute abdomen. You will assume it's appendicitis, it will turn out to be COVID. They can present with immune manifestation like Kawasaki-like syndromes. They can present like a Guillain-Barré. Finally, they can also present fever and septic shock kind of picture, multi-organ dysfunction. Patient presenting and crashing in front of your eyes, not able to do anything, still take protection. So when the patient has come, you've done the routine test, you're still awaiting the RT-PCR, you have not done the RT-PCR, when do we think about COVID? Like for example, the commonest thing is your CBC CRP, most of us do it. An elevated CRP, normal total count with lymphopenia. These patients will have counts of 4,000 to 6,000 with lymphocytes of being 8% or 10%. Relative neutrophilia will be there. That's characteristically seen in COVID infections. Lot of variable things. D-dimer may be elevated, procal can be elevated, tropi can be elevated, LDH, ferritin, all these things can be elevated. Now if somebody comes in, how do you assess whether they have COVID or not? So apart from the examination history taking, three things. Always have a questionnaire. Because Chennai has gone more into the epidemic, now we don't use a questionnaire anymore. Anybody comes with fever, cough and cold, we all definitely screen for COVID. In areas where the incidence is less, you can still have a questionnaire about the symptoms, any symptoms in the family member, any exposure to a COVID patient, any work in high-risk profession like doctors, nurses, police people, those kind of stuff. You can also get a self-declaration saying that whatever they're saying is true because it makes them come out with more truth. Next, how do we go about? An RT-PCR throat swab is what is used more often. And again, remember, as the epidemic advances, as the lab starts doing more and more tests, the experience becomes much more. So what comes out to be around 60%, 50% positivity may become 70%, 80% positivity. But remember, one COVID PCR may not be adequate to rule out COVID. A positive COVID PCR kind of figures or helps you out to decide it's COVID. HRCT test. Somebody presenting with some kind of a fever with shortness of breath. As normal CT essentially rules out COVID. Again, it's only people presenting with shortness of breath. Early fever, CT doesn't figure out anything. Antibody assays and diagnosis, there's no rule. So this is based upon a trial and some recommendation. They're saying you don't need to do imaging for everybody. If somebody is asymptomatic, for example, I have COVID. Then I screen my family member. Family member is completely asymptomatic. You don't need to do any investigation. So routine imaging is not mandatory. But somebody comes symptomatic, a CT test or an X-ray test is really going to help you a lot to rule out a lot of stuff. Next, the role of CT scan. So like most of us are in areas where there is no problem with availability of stuff. You have, even in government centers, CT is easily available, RT-PCR is easily available. So we will decide about areas where everything is available. In that kind of setup, if somebody comes symptomatic, for example, more than 1 week of fever, somebody comes with breathlessness, CT yield is quite high. The simple logistic means somebody with upper respiratory tract infection seldom has fever more than 5 days. But by the time they have come with 1 week of fever, there will be at least some involvement of lung parenchyma. I'm talking about the usual presentation. A CT scan essentially, a normal CT scan essentially rules out COVID in the presence of breathless loss. Next comes, this is the sensitivity specificity of RT-PCR and CT scan. RT-PCR doesn't have a great sensitivity. Specificity is good, also goes on longer in time. A CT, if somebody, let's say somebody presents 7 days of fever or 10 days of fever, negative CT essentially rules out pneumonia. I'm talking about COVID pneumonia. So this is how do your RT-PCR. See, you have to go and touch the nasopharynx. If it goes up and touches the palate, it doesn't really work out much. So it has to go in and touch the palate. Then only your yield will be good. Remember, no test has got 100% negative predictive value. Even a CT scan, if it is done early, it doesn't predict anything. And CT picture is positive for a long time. So if somebody has a CT picture being positive, RT-PCR negative, it could be a healed COVID also. So no test is 100% predictive. Always make sure you see the patient with all due diligence. Keep your paperwork and pathways clear. So in other words, be ready. So next comes, how do we protect ourselves? What are the PPVs used? The most important will be environmental protection. We need to make sure structurally we are protected from that person. Always make sure you have a meter or two away from the patient. Make sure adequate distance is maintained. Make sure you wear a mask, the patient wears a mask. Usual 3-ply mask is more than enough if you maintain adequate distance. You have to go near the patient, examine the patient in detail, then you have to wear an N95 mask. Like for instance, in your usual OPD, if you can put the chair away from you, maintain a longer distance, more than a meter, then your 3-ply should be enough. But if you're going to be in a fever clinic which is overcrowded, where you're not sure you can maintain a 1 meter distance, make sure you wear an N95. And if you're going to the COVID ward, where there's a lot of patients walking around, make sure you wear an N95 mask. So full PPE is not just N95 mask. You should need to make sure ears are covered, your head is covered, your eyes are covered, you need to wear a full apron. So completely wear multiple layers. If multiple layers are especially important when you're going to have areas where there is aerosolization. The commonest area where aerosolization is occur is an ICU area where somebody is on NIV, somebody on BiPAP. So those areas, make sure you layer yourself in multiple layers of things. I'm just talking about 2 areas. Hereafter, you can't have this crowded waiting lounges. It's not going to work out anymore. So if you look into this, you will realize, see, you have seating arrangement. We have put the seats a meter apart. Remember, if it is more than 50% fill, then this model will not work. If you have more than 50% of the seating being taken up by COVID positive patients, it will not work out. Early into the epidemic, you can use your same lounge area. Make sure the seats are 1 meter apart. Everybody wears a N95 and wears a 3-ply mask. The staff who's going to go near or do something can wear an N95 mask. Otherwise, 3-ply should do. There is a meter difference between the reception and the counter. Make sure the toilets are cleaned every hour. Make sure the person doing toilet cleaning is fully protected. The water area, no common water areas. They supplied bottles to the patient. If you have to have a common water area, make sure it is cleaned frequently. Make sure there is enough cross ventilation. Make sure there is a screening at the entry. Let's assume the numbers are becoming more. If you have more patients coming in, almost every other patient walking into your hospital is COVID, then you need to have an open area. You need to have a counter where there will be a partition in between. With this partition, the person will be on the other side and patients will be on the other side. They will have a meter distance. And you will talk with them, check the vitals, the doctor will decide about the prescription and then they go off. If they have some billing or something, again, if you have something kind of a room, put the table in front of it. Again, make sure there's a meter distance. And the patient is on the other side and the whole area should be open with a lot of cross ventilation. Take my word, how much ever you do things with AC and stuff, it will not work out. Natural cross ventilation is probably the best. For any fever clinic, natural cross ventilation becomes very important as the numbers go up. Once you feel that more than 40-50% of your patients coming to the emergency or OP are COVID positive, make sure you use these environmental controls. So for a safe OPD, what do? Maintain a distance from the patient. If you're going to examine the patient in detail, wear an N95. Before and after seeing every patient, we use a hand rub. Use a glove and touch the patient. Remove the glove, wash your hands. Always make sure of maintaining the distance. Avoid touching your own face before washing your hands. So let's say most of us have a consultation room like this. Hardly any cross ventilation. If so, keep your doors open. Make sure that you can leave the door and come into the room, always maintaining 1 meter distance from the patient. So keep the patient away from you, get the history done. If you feel the patient is positive, go out of the room. Make sure you plan about what to do with the patient. Come back, give it to the patient, let the patient leave, make sure the room is cleaned after each and every patient. The cleaning has to be only in the surfaces, it's going to be for a shorter period of time. The patient is in the room coughing for a longer time, it has to be a longer cleaning. Let's say inpatient zone. If you have a window, make sure the window and door is open all the time. Please make sure the exhaust is towards outside. The window is closed and if you open the door, every time you open the door, whatever the air inside is going to come out. So both of them being open helps a lot. A partial opening should be more than enough. So basically, none of us want to become a contact and get isolated. Always maintain your physical distance of more than a meter. Wear a mask. Make sure you see patients in an area with adequate cross ventilation. Avoid touching as much as possible. Make sure you wash your hands frequently. Avoid touching your face. So we have reached a stage where we can get patients from the community infecting our hospital staff. Also, a hospital staff can come into the hospital from taking infection from the community. So all the staff coming into the hospital, they have to be screened every day. You ask them for any symptoms and signs. Every area head, for example, nursing head, in every ward head, they will have to ask them every day. If somebody is symptomatic, they have to be isolated. If any family member of a particular staff is symptomatic, this particular person also has to be isolated. Make sure they do self-report. Self-reporting is very, very important. So, most of the other centers outside Tamil Nadu, outside Chennai may not be in this zone. Chennai now the numbers are going up, so we are getting a lot of these staff coming infected from outside. But slowly as the numbers increase, this is bound to happen. So, what is defined as an exposure? Exposure is something where you're very near to a patient without an N95 mask. Or you've touched a patient and touched your face without washing hands in between. In a room where there is NIV or somebody is in aerosolizing procedure, nebulization. You are intubating or resuscitating a COVID positive patient without protection. You are cleaning a room without a protection or handling a dead body. Let's come to the proper session now. So I'm talking about somebody coming to a fever clinic with a COVID positive report. He's a diabetic, he's 55 years old. Being a diabetic puts him under risk already. Now there are two things, how to protect ourselves and how to proceed with the diagnosis. I've already told you this patient comes to the fever clinic. If your fever clinic is not crowded, you can still stay there with a regular 3-ply mask, ask from a distance, get the vitals checked. The vital shows no hypoxia, you can treat accordingly. You can make everything from a physical distance. The fever clinic is overcrowded, you don't have a choice, make sure you need to go near the patient, examine him rather than patient coming beyond the counter, make sure you wear the full PPE. So most of them will commonly present with a respiratory syndrome. And I say respiratory syndrome, again it fills in. Somebody comes with fever and cold, somebody comes with a sore throat, somebody presents with anosmia, loss of smell, loss of taste. Some of them may come with shortness of breath. If the fever crosses for more than a week, please always consider pneumonia. Remember, in COVID, fever can be there for 14 days. I've had a patient who had fever for 16 days. Patient never required oxygen and went home. I didn't give him anything except supportive care. He just received vitamins. He was a VIP, lot of pressures from everywhere came in. They febrile for 16 days. By 17th day, fever started coming down. Had small spikes of 99 or something after that for a week and finally settled completely. We need to have tremendous amount of patience. Remember, even with prolonged fever, if they don't have hypoxia, if they don't have end organ damage, they're still a mild patient. So when to consider pneumonia? When the fever is there for a long period of time, when they have significant cough, when they have breathlessness. Lot of times elderly people will not say anything. They will just say that I was okay. You told me COVID 1 week back, I was okay for 5 days. Now I'm feeling very tired and weak. Basically, they'll have some hypoxia, which they won't recognize. They come just with weakness and tiredness. That's also a predictor of pneumonia. One thing which we have noticed is this loss of smell is not seen very dramatically in patients presenting with pneumonia. Maybe our elderly cohort is not able to understand that. The presentation with weakness and tiredness is very classically seen in elderly. They may not recognize the fever. If you start monitoring it, you will have mild spikes of 100 or so. Diabetes and obesity. These are the two important things which are the major prognostic factors. So if somebody comes with COVID, we divide them to mild, moderate and severe cases. Mild or young individuals or those who are asymptomatic without any symptoms or mild symptoms. They have stable vitals, no comorbidities. Majority of them do very well. You don't need to do anything. You just need to monitor the temperature. Just give them vitamins for whatever use it may be. You don't need to give them anything. Like the patient I told you, 16 days of fever, no other problem. He was a diabetic under control. I just kept him on vitamins for 16 days and then he became alright. Even if the CT shows some pneumonia features, as long as the patient doesn't have hypoxia, they still come under mild category, and mild category is going to be only supportive care. If they have high risk factors and if they are going to be bedbound, you can try giving heparin for them. But otherwise, there is no role for anything. Again, mild category, we encourage a lot of fluids. We ask them to move around. We ambulate them. We don't try to put them in bed completely. If they're going to be hypoxic only, then only we give them heparin and put them in bed. Then comes the moderate category. Moderate we divide into two categories. One group is the one who has got a lot of comorbidities, but they don't have hypoxia. Majority of management is like mild category. Only thing is we keep monitoring them much more closely because this group can develop hypoxia. They may not be able to pick up hypoxia at times. For example, somebody around 70 may just talk about tiredness. He may not pick up hypoxia. All the sudden deaths you're talking about are all coming through this. There is no sudden death in COVID. They go for prolonged hypoxia. As the hypoxia proceeds, the heart gives up at some time and then they die. So every death in COVID is predictable. Only thing is some of them don't reach the hospital at all. Because when they come to you, you find they're hemodynamically stable. You send them off. Being elderly and weak, they just don't monitor and then slowly hypoxia sets in. Monitoring is very important in this moderate category because obviously now we don't have options to admit everybody. So we need to make sure they're monitored well. Then the patients coming with hypoxia. These people have to be definitely admitted. We try to keep them dry. So if they're going to be negative balance when they come in, majority of them are a bit dehydrated when they come in. Often they are in negative balance. So first day we don't give diuretics unless they're very hypoxic looking fluid overload. We monitor them for around 12 hours. If they're still hypoxic, they're looking good, we give them diuretics. Sometimes when they come in fluid overload, we give them initially. We try to keep them dry. I try to maintain on 300 to 500 liters in the ward. If they're very sick, we go for a larger amount of negative balance. We give them vitamins. We used to give them azithromycin because everybody was giving it. Now we're slowly trying to taper it off and stop it off too. There is no role for azithromycin. Next, heparin. Whenever we give heparin, because these people have a coagulopathy, they have a tendency to develop coagulopathy. So heparin is definitely given, and this group needs to be completely rested. They cannot walk around. This group definitely requests, and we do something called as awake proning, which I'll discuss in detail. If the hypoxia is prolonged, a lot of time what happens, they'll come to you, they'll have a mild hypoxia. Within 6 hours, we'll be able to take them off the oxygen. That group, I still don't prefer dexamethasone. If the hypoxia is prolonged, they require oxygen for quite some time, you anticipate oxygen requirement going up. That's the group which is going to benefit from dexamethasone. Then all these experimental drugs, favipiravir, remdesivir, frankly, we don't have enough data yet. As I put it, they're all experimental. So we use it when the pressure builds up and the family keeps asking, the patient keeps asking, and the patient starts sinking despite all the measures. We use it as an end-on thing. Whether they're going to really help, we are not sure. Whether they're going to harm, we are not sure. Next comes the severe category. I mean, you must have heard Sridhar's lecture. Everything is kind of covered in that. Again, you have to understand tocilizumab and all are experimental. Steroids have a role. Again, your proning, heparin, that's what's going to help you. And more than anything, wait and watch. In the wards, we use a very simple schema because as the epidemic advances, you have too many patients, you have too many calls, you don't know where the patient is, which patient is sick, which patient is stable. So we use 3 simple ways to monitor them. One is fever, because nurses also, as the numbers increase, the patient to nurse ratio will go down. Like, it will be one nurse monitoring 6 or 8 patients. So we don't want the nurses to miss out things. So we use 3 things: fever, hypoxia, patients having tachycardia despite fever being in control for 15 minutes, or hypotension or any kind of organ specific deficits. If the patient have now no problem in any of these, we give them green coat. They're considered very stable. If they have fever, we put them in endo category because they're still having some disease activity. The patient has some hypoxia requiring some oxygen supplementation or some kind of hypotension or tachycardia or new end organ dysfunction, they're all put at a red category. So what will happen, you'll have, every ward will have 4 or 5 red category patients. So the nurses will be able to call you and tell you specifically about red category also alone. You also will have time to understand which patient is sick, which patient is not sick. Similarly, we teach every patient is given a pulse oximeter. We tell them to see the pulse oximeter, use it and tell the sister. So if there's going to be 2 days of green, 3rd day we plan discharge. So one more thing is, a lot of people when they have prolonged fever, during the time of recovery from fever, they have a mild hypoxia. So that's also something we can easily monitor. Next important thing is about this awake proning. This is one thing which seems to show a lot of difference. Because what happens as the lungs become wet, there is going to be irregularity of ventilation. As you make sure that every area gets exposed, like putting yourself in various positions, ventilation probably improves to a significant extent. A lot of them get away with this without going into ventilator. So one is you keep them sitting position or semi-sitting position for 2 hours, put them prone for 2 hours, both the lateral position of 2 hours. This 2 hours can start from half an hour, can go for proning even for 6 to 8 hours depending upon the need. So for us, discharge criteria is very simple. Afebrile for 3 days, they have no supplemental oxygen for 3 days. We don't use routine throat swabbing. We advise home isolation for 2 weeks. If there is a high risk case, we try to monitor SaO2 for a week. Now we are not able to do that. We shifted the onus to the patient. They monitor with the pulse oximeter. We have given them a common line number. If they have a problem, they call the number. So I've completed majority of issues in the first thing. Other 2 will be just differences. Now you have another male coming to you with fever for 7 days. There is no localization. Can it still be COVID? This is a patient who has come to the OPD. They have not come to the fever clinic. He just come with fever. It's about 7 days. So please remember, COVID can still present as an undifferentiated fever with no other localization. But still, it could turn out to be enteric fever. It could be your typhoid. It could be your dengue. It could be a malaria. So again, as usual, examine them completely. Organomegaly is fairly unusual in COVID. Your CBC CRP gives you a lot of idea. Please don't forget to do your blood cultures to rule out enteric fever. your malaria, dengue test. If there's more than a week of fever, do serologies for left-1 scrub. Along with that, please take an RT-PCR for throat swab. So now RT-PCR is negative. This is days after 7 days of fever. Do we say it's not COVID? You're still waiting for the other reports to come. Dengue serology is negative. Malaria is negative. Blood cultures are waited. Can we assume it's not COVID? If there's going to be more than a week of fever, a lot of times what happens? Your PCR becomes negative. By the time they develop pneumonia, there's quite a bit of immune activity. The throat PCR will be negative. Go for a HRCT. This is how the CT came out. This patient is probably having a pneumonia now. His throat swab is negative. He requires treatment as a COVID pneumonia. So this is how the antibody response and antigen or response forms out. The PCR positivity is maximum in the first 5 to 8 days. 5 days for more or less first 5 days for respiratory infection, may go up to 8 days for a pneumonia, not more than 10 days even if you're present with diarrhea. Your antibody response starts around a week to 2, sometimes around 7 days, sometimes around 14 days. Lot of times your IgG and IgM can go parallelly too. So a lot of times it takes up to 3 weeks for your antibody response to be brisk. So the last scenario for the day, elderly patient admitted with fracture on day 3 develops fever. Now this gentleman was screened with a throat swab PCR on as soon as he was admitted. It was negative, CT chest was negative. So can we assume it's non-COVID? You do an examination, check a CBC, take cultures because again you are thinking about other causes, urine routine, D-dimer, lower limb Doppler, but don't forget to repeat your throat swab now. Because once the epidemic becomes, when it starts peaking, they all get exposed. They could have come in the incubation period. During the late incubation period, your PCR will be negative, your chest X-ray or CT will be negative. And the first day of fever, your CT will again be negative. Wait patiently. Don't shift him to the theatre immediately. Do a swab or wait for 48 hours. See how the patient is and take the call. Remember, the maximum infectivity will be the first day of fever. Make sure you isolate the patient. Don't forget the incubation period. Fine. So please consider every patient to be a COVID positive patient or an infected patient during the pandemic. So make sure you minimize the contact time with each and every patient. Ensure your mask is well fitted before you see a patient closely. And when you take your PPEs off, make sure you give them adequate time and do it very slowly and methodically. So next, concentrate on housekeeping. You do everything, the housekeeping comes in infected, he cleans the area, he spreads it everywhere. So the common mistakes we do, surgical mask in the neck, not using hand rub or cleaning your hands after removing PPE, forgetting the apron and running in, a sleeveless apron, it doesn't really work, especially when you're going to be high risk COVID area. Make sure your gown is tied properly, remove and dispose the PPE properly. We do what we are used to. So get used to it. You don't have a choice. For the next 6 months, it's going to be there and probably forever. And make sure you bin your PPEs properly. And last, please don't forget the visitors policy. A lot of times, the common example I give is, I'll have a patient coming with MI. He'll have some CT changes. This patient's PCR will be negative. Very likely this patient has gone to the immune phase. So he's not a risk to you. But his family member who got exposed to him probably will be in the early infective phase. So you may not get it from the patient, you may get it from the attendant. So always make sure your visitor policy, attendant policy is clear. Make sure you protect yourself from them too. Thank you. Hi, we can take some questions, Sridhar.
Hi.
So we'll start with the questions. First question is, SIMV in NIV, will it reduce work of breathing?
So in pressure control mode, I prefer to use pressure control mode in NIV. You can also use the pressure support mode. Usually pressure control probably reduces the work of breathing a little bit more than pressure support. The way you low is working is the patient will look comfortable and respiratory rate will come down.
The next question is, which candidate do we advise admission and versus home quarantine? Basically, anybody coming in category mild or asymptomatic, we advise home quarantine. Next comes a moderate category, that is people who have some comorbidities or who are older. So this group we have to take, it is a toss of a coin, because when we have beds, we were admitting initially. As the epidemic becomes advanced, we don't have enough beds. lot of time when they are stable, we give them a pulse oximeter. We do advise them if they have a choice, they can get admitted. Otherwise, they are monitored. But these elderly people, it's always with a pinch of salt. But take my word, despite the age and comorbidities, sometimes elderly people do really well. But who does well and who sinks is very unclear with one single point of presentation. Next question. If a doctor has to do 6 hours duty in COVID ward, can he join the regular OP the next day? Well, the point is there were two thought processes with regards to exposure. There used to be a thought process that the duration of exposure and intensity of exposure, we really don't have proof about the intensity of exposure and duration of exposure having to do something with the severity of illness. So lot of assumption is PPEs we don't use properly, so we get exposed. So you need to have a period where your symptoms will come out so that we don't infect the usual patients. But take my word, as long as you use your PPEs properly, follow the rules, you should not be infected and you can carry on your normal activity. Dr. Sridhar, can you take the next question? Anticoagulants for how long?
If they are asymptomatic or mild, there is no need for anticoagulation. If they are moderate and they are admitted in hospital, we use anticoagulation for prophylaxis alone. If they got severe disease, we use intermediate dose anticoagulation. Like I said, if I use dalteparin, I use 5,000 units BD. And then if they're going home, we make a decision based on how active they are. Some of them are pretty active when they go home, they're completely back to normal. In them, I don't generally use anticoagulation. However, if they're still going home on home oxygen, we expect some limitation of movement and we expect it'll be a while before they get back to normal, then we would anticoagulate for 15 to 30 days. These are all a little bit arbitrary, but if any of them have had a proven clot during the stay in hospital, either DVT or come back from home with a DVT or a PE, then we would recommend anticoagulation as usual for 3 to 6 months.
You can take the next question also, Dr. Sridhar. Is there any indication to use steroids beyond 10 days?
Absolutely not. So even 10 days, we don't strictly follow. If we see the patient getting better after about 5 to 7 days itself, we are itching to stop steroids because steroid has got other problems. It can cause gastric bleed. Some of them become very weak and it can worsen steroid induced myopathy. Managing their blood sugars become a problem. Already they're stressed, their sugars are quite high. On top, you use steroids, they're often normal patients are needing insulin. We are also worried about secondary bacterial infections, and we know steroids can make this worse. So also the recommendation is 6 milligram once a day for 10 days. If you think the patient has gotten over this severe phase, you're happy to stop it at 5 to 7 days itself. Definitely not more than 10 days.
Adding on to that, like our average duration of admission for a moderate category, I'm not talking about severe categories, 7 to 9 days, which includes 2 days of non-hypoxic period. So basically majority of them, by then we taper and stop it off. There are some patients who start with 8 and then probably they become really sick. We may give them a pulsing too, but it's an individual variation. We try not to give steroid for a longer period of time to avoid immunosuppression. Next, Dr. Vidya wants to know if RT-PCR is positive twice and CT shows GGA. After LMWH, will you consider FabiFlu in asymptomatic patient to reduce viral load? The answer is no. We don't have proof. And if the patient is stable, despite GGAs in the CT without hypoxia, we will treat them as mild case. If they're asymptomatic, we won't give anything. Including LMWH, we will ask them to ambulate. If there are high risk factors, if they have coagulopathy, aspirin is always put in. Low molecular weight is considered if the patient is non-ambulant. Otherwise, we are not giving that. Next question. How to identify a COVID-19 or not, patient is COVID-19 or not, as few people seems normal when we see in OPD, as it is having a window period of 14 days. Unless a patient presents with symptoms, you will not be able to figure out a patient having COVID or not. There is a play or two called as pre-symptomatic phase, where the patient may be infective but may not have symptoms. That is a day before he has overt symptoms. So during an epidemic, every patient you meet, every attender you meet is assumed to be COVID positive. So always maintain your 1 meter distance. Always make sure you wear a mask and don't touch unnecessarily. Next question. Sridhar. I think you should take this question. Do vitamins really have a role in COVID-19? Sridhar's favorite question.
Absolutely no. But what I have had is I give so less medicines that I've had patients turn around and say, for the medicines you're giving me, I could have stayed at home. So I encourage them to go home. Vitamins, it is not really harmless. Our nurses are having to administer this frequently. It is an additional workload already overburdened nurses. So a lot of my colleagues prescribe it. I enjoy crossing it out.
See, I told you his favorite question. Next is false positive dengue serology in COVID. Yes, it can happen. So apparently you can have false positive reports with dengue, and also sometimes you can have false positive report in chikungunya also. Now, till now, we have not had the dengue season. So next 2 months, we're going to have a tough time. But we basically look into the clinical picture also. Think about RT-PCR, probably antibody testing if they come present late in the immune phase, and then take a call. Dr. Sridhar.
Yeah, so the next question is, does dexamethasone in diabetic patients, do their sugars spike needing insulin? Yes, it does. Even patients who are not diabetic, giving dexamethasone on top of a critical illness can cause the sugars to rise to a point wherein they need insulin. Yes, that happens. CT chest scoring any different in a patient with baseline lung pathology, COPD, old patient? No, it is more or less the same. We can see the old pathology and we see the extent of normal lung involvement in these patients.
Is it more or psychological vaccination that homeopathy, non-allopathic drugs are given, or do they really help? Being an allopathic practitioner, I don't know. I don't give homeopathic or other drugs. Vaccination, we have to wait for that. Yes, psychological interventions help even for doctors because we are also quite stressed now.
See, I would like to answer that question too. I believe a lot of the allopathy drugs itself don't work, leave alone the homeopathy and non-allopathy drugs. So the difference between the medicine we do and the medicine that other specialties follow is this. We want proof that it works. If we use our own drugs without proof, then that is no different from homeopathy.
Then CT score of 21, what do you recommend?
This is a interesting question. So the CT score of 21 means definitely the patient is sick. I assume this score is 21 out of 25. It means that the lung involvement is quite extensive. It is 80%. This is definitely severe COVID. We will have to admit this patient in a critical care area and do all the things that I said during my talk.
So when do we repeat a CT? If a patient is worsening, you want to see whether there is sudden worsening, then you repeat it. Or if you're thinking in terms of a trauma to the lung, some barotrauma or something, then you do it. There is no role for routinely doing X-rays or repeating CTs without any clinical correlation. Any role for antiplatelet agents, aspirin in patients with mild, moderate symptomatic patient home quarantine? If you are a diabetic, above 60, 65, especially uncontrolled sugars, we always advise them to take aspirin because the rates of acute coronary syndrome seems to be pretty high in patients who have even recovered out of COVID. So we know that even in other patients, elderly patients admitted for other illnesses also, any prolonged hospital stay, prolonged ICU stay, the infection rates and coronary event rates are much higher in the next 3 months. Same applies to COVID too. We are still waiting the data. So if they have high risk, we always advise aspirin. Sridhar, success rate of intubation.
Difficult question. So from reports coming from various countries abroad, the success rate, in other words, the people who survive intubation ranges from 30 to 50%, depending on center to center. Within Chennai, speaking anonymously, it depends to a large extent on the group of patients you're taking. If you're taking a lot of patients who are 80, 85, 90 and intubating all of them, clearly your success rate will become low. Whereas if you're forming some form of, triage and saying we'll intubate only those patients who have got the best possibility of recovery, then clearly your intubation rate, your success rate from intubation will be higher. It depends on the population that you're addressing. I know that's not the answer, that it's not a clear-cut answer, but it depends on the substrate, depends on the denominator.
We probably will be able to answer after 3 more months. Then steroids and CRRT.
Steroids leading to hyperglycemia can cause water and electrolyte imbalance due to osmotic diuresis. Would you still run your patient dry? Does it increase the need for CRRT? So I like running my patients dry, but however, I've also had patients who have come to me after quite sick after 10 days of fever. And to start off with itself, they have got acute kidney injury. The urea is about 120, creatinine is about 2. So these are people who have become dehydrated as a consequence of their illness, fever, inadequate oral intake. So clearly, it would not be wise to run these patients dry. As I said, the sick patients who are hypoxic and needing a lot of oxygen, I would like to run them dry. And by and large, I'll know the extent to which I'm running them dry by looking at the urea. So the urea will rise to about double what it normally does, and I'd be happy with that. And then I would wait and see. That would sort of be my threshold for which I would confidently diurese. One of the patients who we intubated, the urea actually tripled. But we continued doing, we stopped it, and she was extubated in about 7 days, which is sort of a record, because most people who get intubated stay intubated for about 10 to 14 days from Western data. So I think we know from previous viral ARDS that running people dry shortens their time on ventilators.
Role of indomethacin in improving oxygen saturation, hypoxic period? No, there's no role. Next, Sridhar, diuretics guidelines. You want to give them a rough guideline or anything?
Rough guideline is, once again, if the patient is already dehydrated, already got acute kidney injury because of the underlying illness, then clearly you would not want to aggravate this by making them by drying them out. But if they came with normal urea and they are hypoxic and they're not very sick, then we like to give simple IV furosemide because they are in the ward in order to reduce their workload on the nurses. But if they are sick and they're coming to ICU, I like to run a furosemide infusion. This will ensure that they don't pass a huge amount of urine at one time, but gradually you get them dry over 24 hours, also reducing the chance of hypotension in these patients. So if they are stable on the ward, 40 milligram BD sounds reasonable. If they are in a critical care area, anywhere between 2 milligram per hour to 10 milligram per hour, depending on how sick we are. No absolute values. Try and get them negative by about 500 ml every day.
Somebody asked about ivermectin. We don't know. We don't use. It's again somebody's hypothesis. Now somebody wants to know when do we think that COVID will get away? We can go back to routine. It's very difficult to say. It's going to be with us. It's not going to go away anyway. Probably another 3 to 6 months, we may go back to regular routine. Our regular routine will never be the same again. Next, CT bad after 2 weeks. You think of antivirals? Sridhar?
I don't think of antivirals even in the first week. So after 2 weeks, definitely no role. In the first week of illness is when the viral replication is maximum. So if you think that it might be benefit, probably there is a time to try. Definitely not after 2 weeks. And I would personally, I can talk confidently. Personally, I would not take it even the first week for me also, or my family.
Is there a chance of getting COVID-19 again? See, you can have relapses. We've had a patient who was with us with CT changes and initially COVID PCR being negative. She came back after a month. She was on steroids and ATT because we were thinking about TB meningitis because she had some meningitis and stuff. She had a COVID positivity. So these kind of recrudescence relapses are seen throughout in India. It happens for around a month or 1.5 months at the maximum. Reinfection, as of now, we seem to be getting enough evidence of good immunity. At least immunity seems to be there for at least 3 to 6 months. So reinfection rates is something which we are not worried about at this point of time. Elective surgery, RT-PCR positive at least 2 weeks. Would you prefer IV infusion or subcutaneous insulin to control hyperglycemia? Sliding scale, even the sliding scales are labor intensive.
So it depends on what you have. So our ICU is still well staffed. So in ICUs, I'd like to use IV. But clearly, if I'm using it outside ICU and the patient there's no other indication for the patient to come to ICU, for both safety reasons and labor intensive reasons, I'm happy to use subcutaneous insulin as well.
Role of lifestyle modification with steam inhalation, saltwater goggling, hypothetical healthy food, activity, because they say if your physical activity is good, if you're not obese, it helps, but nothing in the short term. Indication of ECMO, Sridhar.
So ECMO is probably indicated if your maximal treatment, which in this case would be intubation and ventilation, despite that the patient is hypoxic and the patient is continuing to deteriorate, then ECMO can be considered. How long? Depends on how long it takes for the patient to get better. Sometimes people have stayed in ECMO for weeks together before they get better.
Now, next one more question about what is advice to practicing physician, what to do and when to refer. So basically, the biggest reason where we lose patients is hypoglycemia. The hypoxia is so slow. Patient's body gets so used to it, they don't really recognize it. So most of us don't even figure out that we have hypoxia. So that is something which needs to be monitored. So if you have a patient coming in with COVID or fever, you have a doubt, some of them don't even want to do tests. Make sure we monitor their hypoxia. There's a simple pulse oximeter which they can use at home. If there is hypoxia, they have to go for admission. They have to be monitored. Oxygenation is very important. So if it's young, asymptomatic, they're panicking, normal oxygen saturation, no features of acute coronary, they can very well be at home. Anybody, if there is hypoxia, if the patient's not looking good and use something with any end organ dysfunction, then they have to be referred, including a kidney involvement or a stroke or chest pain, anything out of ordinary, they have to be referred out. Any role for MMR? No, we still don't have proof that MMR has any kind of protection against SARS-CoV. Do we need a separate team to look after COVID? Sridhar?
Practically, I don't think it's possible. I think our resources are stretched. I think if you ask me openly, I think we have to use all the resources we have currently to target this, which is overwhelming us. To divide what we have into two and it's not ideal. It's like in the face of an enemy, dividing your army into two groups.
Next is LMWH and elective LSCS. In asymptomatic COVID, you treat them, in an asymptomatic COVID patient, you treat them as a normal patient, because asymptomatic COVID is just a colonizer. They don't have any kind of pathological problem with their lungs. So you don't treat them any differently. Do you see patients with complications developing after 2 weeks? Initially mild for the first 2 weeks. So basically, it's a very slow progressing hypoxia. So if you ask them and prod, they will say that they've had mild fever. So it's not like it never comes up. Somebody doesn't have fever, completely fine. Suddenly after 2 weeks, they develop sudden hypoxia. It doesn't happen that way. They will have some low-grade fevers. There'll be some hypoxia which goes on and on. Then they become sick. One event which can happen after some time is MI. The acute coronary event seems to be much higher in this group. They recover out of COVID and then they can develop an MI and come back. So generally, most of the patients who develop hypoxia or present late have been having mild hypoxia and fever for some time. Somebody wants to know, do we need negative pressure in OT? If you can get a negative pressure done in OT, it's extremely good. If you can't, the few things which you can do is, so in the OT, make sure you take full protection, including your N95 mask, make sealing being really good. And make sure you go for spinal or local rather than GA whenever it's possible. If it's not an emergency case, try to avoid operating for at least 1 or 2 weeks, at least not in the first 5 days when they're extremely symptomatic, because the maximum infectivity starts from the day of symptom onset. And the maximum infectivity will be the first 3 to 5 days, at least tied over that period if it's not an emergency surgery. If it's an emergency surgery and patient comes in symptomatic and they are COVID positive, make sure your N95 is completely sealed, you're fully done. If you can actually stop your AC for some time, make sure there is no positive pressure for some time and take them up. If you can't, no problem, seal yourself, complete the surgery, keep the patient in the theater for some time, you go out and then shift the patient straight to isolation area, close the OT doors for another hour and then start cleaning. Increase in procal, does it indicate secondary bacterial infection? It can. Sometimes a procal elevation, the patients don't do well. You start antibiotics whenever procal is elevated. When the procal elevation is there, your cultures are all negative. Isolated procal elevation as a patient sinks is not a good sign. Next is staff low-grade fever, COVID negative 48 hours, cultures negative, CT chest, old fever, how long to quarantine? So if it's COVID negative, then you treat as a normal person. If the patient has been exposed to COVID, you assume they've got COVID. Once the symptom stops, at least 10 days after that. So roughly around 14 days it will come to. How to differentiate from swine flu? Can we put on oseltamivir? You can't differentiate from swine flu clinically. If your COVID is positive, there is no role for oseltamivir. Sridhar, can you take this question? Relationship between COVID and AKI, COVID and cardiovascular system.
So Once again, the reports internationally are varying. They're saying acute kidney injury. The reports from all over the world are different. Some people are reporting as low as 5% incidence of acute kidney injury in the COVID patients. Some people are reporting as high as 30%. So I think it varies a lot depending on your underlying population. I per se have not seen COVID-induced acute kidney injury. I've seen a bit of dehydration cause some mild.
One patient.
Yeah, and also people who have had previous chronic kidney disease coming in. That's much more common because I think people with CKD, their immunity is lower. So I think it's much more likely that they get COVID compared to others.
There's one question on pregnant COVID women, COVID negative women, 24 hours back, mild temperature in labor, leukocytosis, CRP raised. See, when you have a doubt, assume the patient is COVID positive. Take your precautions when you operate on them or induce labor, because the worry is you getting infected from the patient. You have all the time once the emergency is over. During the emergency, wear full PPE, put it on, put them in a separate room, put them on droplet precautions. You can anyway repeat your swab or repeat a CT and take the call afterwards.
So I have one on when the relatives put pressure on using experimental drugs. How do I handle it? I think this is a very common problem that all of us are facing. See, I don't make the distinction between homeopathy and allopathy quite casually. We are using drugs that were developed by indigenous medicines. We use artesunate, which was from a Chinese herbal product. We use digoxin. So the question is, does it work or not? That is the key question. And I think as all allopathic medicines that if used inappropriately are equivalent to homeopathy. Having said that, the trouble that we are now facing is that there is a lot of experimental drugs. I think we all know about at least another 20 drugs that we all here are being trialed upon. And we do not know what the results of these studies would be. So what I tell the family members of people who are demanding experimental drugs is, I do not believe it works. I personally would not use it. But we should be mindful that it's quite possible 6 months down the line or a year down the line, a study might show that one of these 30 or 40 drugs could potentially benefit in a very small number of patients. Like I said, we are saying Dex is a lifesaver. But remember, if we give 25 people on hypoxia Dex, only one of them will benefit. So 24 of them will not benefit. And even that is touted as a major benefit. So it's quite possible that one of the 20 drugs that we are not using or considered experimental therapies might 1 year down the line show some benefit. And we might have a family that would regret that we did not use that medicine. So I'm quite clear when I speak to such families, I say, I will not use it for myself. I will not use it for my family member. But if you feel strongly that this can potentially benefit, I'm happy to go along and respect your wishes. Just so that they feel that there was no stone left unturned in the care of the attenders. So I take a pragmatic way.
Or mild cases allowed to walk or exercise. We encourage mild patients to walk, take plenty of fluid, in contrary to moderate patients and those requiring hypoxia where we fluid restrict. Because mild patients, generally they do well. They don't really have a wet, hugely pneumonic lung. So good hydration, managing fever, walking around decreases the chance of coagulopathy. We generally don't do a 6-minute walk test in the OPD because we don't want to infect people around us. If there is hypoxia, they have to be put on bed. Otherwise, they have to walk. No strenuous exercise though. Then difference, when do you use 3-ply and when do you use N95? If you're away from a patient in an area with good cross ventilation, 3-ply mask is more than enough. If you have to examine a patient at close quarters, like just not take a, like say, pulse oximeter usage or something. You have to examine a patient completely, put a line, or you're going to go into an area with a lot of COVID patients, then you wear an N95. Sridhar, how long can we maintain patients on HFNO, provided the patient is maintaining SpO2 of 90?
There's no upper limit. In fact, sometimes when patients get better and their FiO2 comes down to 30 or 40%, and I expect a long course, I would leave them on HFNO because on a long course of giving oxygen through some other thing, using cold, dry air may not be that beneficial. But once again, when a pandemic situation, it is quite possible that a patient has improved to the point that they don't need HFNO, but somebody else might benefit from that. At which point, you need to make a judgment on who's going to need it most and who's going to benefit most. Upper limit, no limit. You can continue. People are on home oxygen for years. High flow oxygen, which is humidified and warm, there's no upper limit on duration of use.
Ferritin and LDH as prognosticators, we have not found a great prognostic benefits with ferritin, LDH, even IL-6. It's a very slow progressing hypoxia, unlike the Western belief of this intense cytokine storm. Nobody develops a sudden cytokine storm and just crashes down. It's a very slow process which goes on for days. And ferritin LDH may have some kind of a role in diagnosing, but serial monitoring, we have not found any trends in both of them. Sridhar, SpO2 below 92, otherwise asymptomatic. Should we admit and monitor? My answer would be yes.
Yeah, I think so. I think so too. Because it's below 92, you don't know at what position, you don't know how the disease is going to progress over the next few days. Always below 92, I'd worry about them. I would definitely advise admission and monitor.
In your hospital, any non-COVID patients become COVID. A lot of times your first COVID sample may not be positive. If your prediction of COVID is very high, repeat the COVID test. Don't go by one COVID test alone. And if the clinical suggestion is extremely high, even if the two COVIDs are negative and CT is suggested, still assume them to be COVID. Keep them in COVID area. Don't allow a freeway for the attenders, because you can get it and get yourself infected from the attendants too. Anything else? They've got too many questions. Prophylaxis for doctors who treat COVID, none. A good, properly fitted mask and good full PPE.
So if COVID positive after 2 weeks isolation, can we avoid home isolation?
COVID, don't repeat COVID test.
And it's also important to see that in case it has been repeated, from the day of onset of symptoms, nobody has been proven to be infectious after 11 or 12 days. You can still be positive, because remember, the RT-PCR is only testing for RNA. Dead virus will still be shed, and the RT-PCR will pick up dead virus and come back as positive, and in fact, you're non-infectious. I would say from the time of onset of symptoms, 2 weeks afterwards, you're extremely unlikely to be infectious, even if the RT-PCR, which you shouldn't do, turns out to be positive.
See, the risk of aggravation of thrombosis of maintaining negative balance. Interesting question. We have not had any.
Yeah, that is true. But remember, I'm not using prophylactic dalteparin. I'm using intermediate dose dalteparin.
See, that's his innovation. That's his own innovation.
I don't know. It's a true question. It's a valid question, and yeah, it is possible. But we're using a slightly higher dose of dalteparin. Nobody knows which is going to benefit whom. But in somebody, I think the key goal is, if they're severely hypoxic, they're very likely to end up on the ventilator, and they're also likely to get a DVT or a clot, but they're much more likely to end up on the ventilator. So I'd focus on my immediate problem in severely hypoxic patients, which is to try and stop them from getting ventilated.
We have not had any patient that way till now. Touch wood. So we are actually going in probably the right path. COVID positivity is not an indication for LSCS. If the patient is hypoxic, then you go ahead with LSCS because you want to. Because once the baby comes out, we had a patient presenting with around 37 weeks hypoxic, very high CT score. Once the LSCS was done, the next day the lady needed oxygen. Third day we were able to take her off oxygen. We discharged her on the 4th or 5th day. N95 mask reuse. We still don't reuse in clinical area. So non-clinical area, sometimes it's reused. Clinical area, COVID areas, we don't reuse it. And sterilization, there's been some data on plasma sterilization. So AIMS, they ask them to put it in a bag and keep it for 4-5 days and reuse it. Still, data is limited. So COVID areas where you come across a lot of patients who are infected, try avoiding reusing. Sridhar, you want to take this question? Mortality, morbidity in LSCS patients with COVID. We haven't seen any.
Yeah, so young patient, otherwise fit and well, they all do extremely well.
Somebody wants to know, if a COVID patient becomes COVID positive in the hospital, are we penalized? Do we take consent? If patient becomes positive, are we penalized? Well, no, this is an epidemic. And like when it's a pandemic. So people can get infected anywhere. We cannot be penalized.
We do take a letter of undertaking. I think most hospitals are doing this. They take a letter of undertaking.
They sent a mail saying that in a pandemic, you cannot be legally penalized. That's the legal opinion. Okay, any other questions? False positive PCRs, yes, like the false positivity rate in a single PCR will be less, but then your PCR can remain positive for even 6 to 8 weeks, where the patient has recovered from the infection, but PCR can still be positive. Atypical presentation, we've had a GBS, we've had MI, we have had patients presenting with one patient with a kidney injury, we've had a patient with arrhythmia, we have had a patient with we have patient presenting with conjunctivitis, patients with mouth ulcers, then a lot of patients with loss of smell. Anything else, Sridhar? Atypical presentations. MI strokes. We had quite a few patients with strokes.
Young strokes, yes.
Young strokes.
We do have some couple of patients with GBS, one of whom is positive. Once again, it's hard to say whether this is incidental or causative.
And yeah, I think that's it. Suddenly it's not coming to my mind. I think there are too many questions. Can we just answer the rest? You want to take some more? Negative fluid balance maintenance in a renal compromise scenario, how to handle it?
So once again, I think the question is how to handle it. Is if this is chronic renal disease, then we anyway like to run them needing dialysis. Then anyway we like to run them on a negative thing. But if we believe improving the perfusion will improve urea and creatinine, then I would give the fluid gently.
Period of infectivity is symptomatic. You remember, we have a phase where initially patient has a lot of virus. The virus goes through the blood and is secreted out through the secretions. Then what happens? Body's immunity takes over. During that phase, P1 can still be there. They have presentation with pneumonia, sometimes with all those immune manifestations, some kind of serious CNS manifestation, other manifestations come. Generally, people are not infective after the immune phase sets in. The immune phase can set in as early as 5 days. It can go up till 10, 12 days, at the maximum 14 days. Patients are seldom infective after 14 days, but we have had a couple of cases, I think some abroad too, where the patient RT-PCR has been positive after some time with symptoms. These patients are assumed to be relapses. What is the percentage? How do we predict it? We are still not sure. But majority of patients, I would say more than 99% of our patients will be non-infective after a week's time, despite having fever. Encephalitis, we have had one doubtful case, but not much. Any other question? If attender is positive, do we consider the patient as suspect even if she is negative? Yes. And the point, the patient could have been the primary attender, could have got it from the patient, or the patient could be in the incubation period. So you need to take the precautions. Any questions? If COVID positive then became negative, no need to take, you can just treat the patient as a usual patient. Yes, we are categorizing patients into COVID and non-COVID area. We try non-COVID patients, we completely have clear different zones and there is no admixing. Any other questions? Patient with COVID, not tachypneic, no increase in respiratory rate, but SP out of 85. So this is how we classically see our patients. They walk to the OPD, they will just say, I'm tired, have some low-grade fever. You measure their SpO2, it will be 75, it will be 85. So this is how elderly patients present to us. So we need to be really careful. They will not recognize hypoxia. They will not be clearly tachypneic. This is the group which has to be admitted, which has to be monitored stringently. They are the ones who can go for death, sudden death. Suddenly you'll find them being unconscious or some sudden MI, sudden deaths are all this group of people. Case numbers down in North Madras due to herd immunity, probably it could also be because they were managed well, they were made to stay indoors. Anything is possible. In OP building, can we give one floor to COVID patients? Depending upon your pathways, yes. 3-ply layer over an N95 mask, double masking, you can, but still, if it's going to be a COVID area, especially if you're going to be in ICU and all, I would still be against reusing N95. If you're going to be in the OPD, not seeing many patients, if you're just going to walk around in the fever clinic, maybe you can. But ICU areas where there is aerosolization, try avoiding reusing the N95. So the simple logistic, why do you cover yourself from head to foot? This is a droplet mediated infection. You don't want any surface of your body to harbor the virus, and then you don't want it going through your eyes or nose. And N95, you don't want to breathe in. So breathing, you've anyway stopped. If you go out, if you touch the exterior of the mask and touch your face, again, you're going to get infected. If it's a non-aerosol zone, yes, maybe yes. But if it's going to be in the aerosol zone, no reuse. I think that's it. Thanks, Dr. Sridhar. Anything else?
Nothing else. So
I
thank you.
think you have one more question. HFNO with saturation of 85 to 88, non-tachypnic, conscious, alert. Do we need to intubate? Even I want to know the answer.
Have you dried the patient out? Have you tried different positions of the patient? That would be the question. I would try drying the patient out. So this is a kind of patient I would really aggressively dry out because we are on the edge. We are very close to intubation. So this patient, I'd give a big dose of furosemide bolus and follow it up with 10 milligram per hour, and definitely prone this patient.
This is zoonotic transmission is probably yes. Airborne transmission, it is droplet. It's the particles are larger, so they settle down by a meter's time. If somebody is singing, somebody is shouting, it may go for a slightly larger distance, but it is not like TB organism which can stay suspended in the air for a longer period of time. It is definitely not like TB or chickenpox where it can stay for a longer time. I think that's it. Thanks a lot. We had a wonderful time. If there are any more questions, we'll take it up. We will message the answers back. Thank you.
Thank you all. Thank you all.